Assalamualaikum and very good evening to my fellow friends and my tutor. I want to introduce myself. My name is SUHAIME bin Abdullah. My magic number is 931009095073 and 002. I'm a student of Bachelor of Medical and Health Sciences with honor. This presentation for subject Nbcp 2626 clinical practice trauma and emergency care. I was student in Alostar Learning Center, and I went to before this I was medical clinical posting at emergency and trauma department and hospital Bukit Mertajam. Okay, I want to tell you to the derivation of polytrauma. Polytrauma is defined as injury to several more than one physical region or organ system where at least one injury or the combination of several injury is life-threatening, with the severity of injury being more 16 on the scale of the injury severity score, or we call it as ISS. Okay, these are type of accident: road traffic accident, industrial accident, sport accident, accident in leisure time, accident in home, violent crime, burial, suicide attempt, effect of was, accident caused by internal condition, example heart attack. Okay, suspicious of polytrauma in the case of a fall from a height of greater than 3 meters, ejection from a vehicle, the death of fellow passenger, a pedestrian or cyclist collision with a car, a high-speed motorcycle or car accident as treatment, pinning or burial, injuries caused by explosion, obvious exposure to a large amount of energy. This all of the injury can cause to a polytrauma injury. Okay, dysfunctional of injury severity score ISS or an abbreviated injury score AIS. These are introduced to assess the severity of multiple injury to a given anatomy organ and graded 1 to 6 in ascending severity and 6 being unsurvivable. This score decided and assigns to an injury by cross-referencing at least two or preferentially three sources of information, which are radiological data, operating note, and communication with the operating team with surgeon. There are 5 body regions, and the top 3 scoring injury are identified. Each of 3 AIS score R squared, and the sum total constitute as injury severity score ISS. This I will take this function from Hospital Sultanah Aminah 2012. Okay, this how we take the score from the abbreviated injury scale. That I will show this the injury, shoulder pain, no injury specific, where the score is 0. Shoulder pain, no injury specific is 0. Wrist pain, I'm sorry, uh, wrist sprain 1 or minor, closed undisplaced tibial fracture 2 or moderate, head injury, unconscious on admission but for less than 1 hour thereafter. No neurological deficit is 3 or serious. Major liver laceration, no loss of tissue 4 or severe. Incomplete transaction of the thoracic aorta or 5 is critical, and the last is a laceration of the brain system is 6 or fatal. Okay, this definition of intracranial bleeding. Intracranial bleeding is a hemorrhage or bleeding within the skull. It occurs due to physical trauma like head injury or non-trauma such as ruptured aneurysm. Intracranial bleeding occurs when a blood vessel within the skull rupture or leaks. intracranial bleeding needs medical emergency treatment because it can increase the intracranial pressure. Severe intracranial pressure can result potentially deadly brain. Usually, CT scan or computed tomography is the use for the accurate diagnosis of intracranial bleeding. Okay, this is my presentation of the case. My patient is named Liu Mei Sing, said is male, registration number HBM 145.045. The date and time the patient come to hospital Bukit Mentajam is 18 November 2020 at 9:50 a.m. The patient it was Chinese and the age of the patient is 53 years old and occupation was a policeman. Okay, the patient come with alleged motorbike skidded, sustained deep laceration of her forehead, 1/7. Okay, history of present illness. On the day of accident, he was riding motorcycle or motorbike as usual. Wear a helmet at 6:15 a.m. in the morning. He took a shortcut road. Suddenly, his motorcycle was skidded after past the bump. He then fell forward. He was found by his colleagues still unconscious but had heavy bleeding from the skull. He got a deep laceration about 5 to 8 centimeters over forehead. His friend brought to Klinik Kesihatan Bukit Minyak around 7:30 a.m. Emergency treatment was given immediately by care provider. He was set by IV Abdullah 18G and normal line in maintenance. Upon arrival, he still responsible, no retrograde amnesia, no vomiting, and no loss of consciousness. But this patient was got the ENT bleeding come from nose. The GCS or glaucoma scale was I3, verbal 3, and motor 5, and the total of GCS is 11/15. The bleeding from skull still oozing, and the dressing was applied with slight pressure on the head to stop the bleeding. Oxygen saturation is 90% under room air, and patient was given high flow mask. His face also not to have a vacant eyes in the right eyes. Okay, the general condition of the patient, patient was alert conscious. We can use AVPU or alert verbal pain and unresponsive to know how the mental status of the patient. So the every patient is every pattern able to talk, no vomiting, no retrograde amnesia, ENT bleeding can come from nose, no maxillofacial injury. The patient breathing, no tracheal deviation, good chest expansion, good air entry, no paradoxical movement. This patient also non-deformity seen. Capillary refill test is under 2 seconds. Pulse was palpable over upper and lower limb. Disability, the GCS patient come to Klinik Kesihatan Bukit Minyak is 11/15. Patient was referred to Hospital Bukit Mentajam for further management. Okay, the vital sign. We can see this have two vital sign. The first vital sign is by open arrival at KK Bukit Minyak. The blood pressure is 115/100 millimeter mercury and pulse rate is 83 per minute. SpO2 patient is 90% under room air and pick up to 95% under high flow mask. Then the temperature is 37.2 and then ECG was the sinus rhythm. While patient referred to hospital Bukit Mentajam, vital sign at emergency department hospital Bukit Mentajam, the blood pressure is increased to 205/125 millimeter mercury, and the pulse rate is 100 per minute, and SpO2 was dropped to 88% under room air, and temperature is 36.7. Then ECG still a sinus rhythm. Okay, the past medical history, past surgical history, and social history. Patient will have a known case of hypertension and diabetes mellitus on medication. Patient on tab amlodipine 5 mg OD with tab metformin 500 mg BD. They never have a diagnostic history and social history. Patient was widowed, stay alone, and ADL was good. Okay, assessment of finding for this patient, we have to assess the head, and this is the first step in the physical examination is to assess the head of patient, inspect the scalp laceration or contusion, palpate the scar tenderness, hematoma or depression from the head assessment. This patient, Mr. Liu Messing, had a laceration of forehead is about just 8 centimeter of the right temporal parietal with depressed skull fracture with hematoma. This patient also have a right vacant eyes, abrasion over right maxilla, and the bleeding from the laceration wound. And the surgery was done with care provider or assistant medical officer at KK Bukit Minyak. And but the patient laceration still in bleeding, then can cause to hypovolemic shock if can we not to secure uh, the wound. Okay, the number two is assess the neck. Second step is to assess the neck, inspect and palpate for injury or sign injury, jugular vein distension, tracheal deviation, crepitation, and apply cervical spinal immobilization collar from the examination. This patient, Mr. Liu Mensing, do not have any deformity, no tracheal deviation or jugular vein distension. If there is a tracheal deviation, it can show the patient having pneumothorax, hemothorax, pneumohemothorax, or another else about the life-threatening trauma. Okay, the number three, we have to assess the chest and lung. We have to inspect the thoracic division and palpation, no carpitus or chest spring to and this patient chest spring was negative, percussion, no hyperresonant and downward sound, and the auscultation patient the equal patient was called the equal air entry. Okay, and the assess the abdomen. Assessment was done to identify whether the abdomen is firm, soft, and or distended. From the examination, the special Mr. Liu Messing has a scopic abdomen. Scopic abdomens occur when the stomach appears to be deflate and concave instead of being convex or pushed outward. Patient also we have to assess the pelvic in case patient got to pelvic fracture or observe the bruise, bleeding, swelling, and other deformity. Patient have no deformity and no obvious bleeding. Pelvic spring was done and the result show negative. This the past present. Assess the extremities. Patient has multiple abrasion or wound over right left hand, right knee, and but the patient can move all four limb. And next, patient, we have to assess the posterior body. We must to check the log roll or roll patient with spinal percussion and assess posterior body, inspect and palpate, examine for injuries, severity patient, and this patient I show all the when we done the log roll that show a negative so this patient no steroid deformity, no bruising, no hematoma, and anatome no overriding prostate. Okay, the about the cardiovascular system, this patient overall Alert, ping, CRT, secondary, less than 2 seconds, no sign of hypoperfusion, and the ascotate of this CVS or cardiovascular system. This patient was dual rhythm normal, and the palpation pulse was good. About the ophthalmologist, the patient got recognized of right eyes, ear, nose, and throat. Patient was got the ENT bleeding come from nose. Okay, assessment mental status. We can use the AVPU. A stand for alert, V verbal, P pain, and U stand for unresponsive. Okay, patient mental status assessed by their level of responsiveness, respond to external stimuli, and orientation to time and place. Responsiveness can be evaluated using mnemonics AVPU. Okay, A alert, patient which alert with the surrounding and well orientated. V verbal, patient responsive to verbal stimulation. For example, patient say words and answer to the question we ask for to him. And the pain, patient respond to pain. Unresponsive patient, no response at all. Patient is alert conscious. Okay. After we receive this patient, we make the investigation. We do the fast or focused abdominal sonography for trauma to identify any free fluid in the body lah. Fast scan done to Mr. Liu Messing and it showed no free fluid. Then repeated by 3 times, but it also show the negative. Okay, we do the CT scan and this CT scan finding. We can see the result CT scan finding to Mr. Liu Messing was got ventricular affected, no obvious midline shift, air fluid level at right ethmoid and maxillary sinus, right orbital wall fracture, periorbital edema on the right side, left hemisphere edema, left subtemporal contusions bleed, left occipital EDH or epidural hemorrhage, occipital subarachnoid hemorrhage, SAH more on left-sided, scalp hematoma and right temporoparental, scalp fracture over the uh, left temporal segment, and the suture diathesis over the occipital place. For the medical and surgical management, this patient we have to maintain the airway pattern. Airway pattern we got two is the number one is uh, not for trauma. We can use the head teaching lift, and the trauma we can use the jaw thrust. Okay. And this patient, we have to use the fluid resuscitation, a minimum 2 large bomb in granular intravenous catheter 40G until 16G intravenous fluid therapy with crystalloid be initiated, which are normal saline and Hartmann solution. Patient was given 4 pint normal saline. First 2 pint run fast, then followed by 100 ml per hour. He also received 2 pint PET cell in view of hemoglobin was going down from 12.2 to 9.7 in half an hour due to non-stop bleeding at the frontal. This patient, we have to monitor vital sign and urine output. Okay, the observation was performed on patient by the blood pressure, pulse rate, and body temperature. Or we can use the research chart and to monitor all what medication we given to patient and what the procedure we done to patient. Okay, okay, GCS. We always to monitor patient by GCS. GCS is a scale that used to measure the consciousness and degree of brain injury of a patient. It evaluates visual, motor, and verbal responses to stimuli from the 3 categories. The total GCS help doctor to identify a patient conscious and extent of brain injury. A lower score indicates severe injury and the pure prognosis. Okay, this patient we have to give the medication like IV metformin and the IV monitor for the painkiller. which should be given in small dose and repeated as needed. Okay, this patient was diagnosed alleged motor vehicle accident secondary to intracranial bleeding. A patient was referred to Hospital Pulau Pinang under neurosurgery and surgical department. Patient can follow up to can't to follow up at Hospital Bukit Mertajam because Hospital Bukit Mertajam doesn't have the neurosurgery department and surgical department for the further management lah. Okay, these are my references. We I got to make this video on presentation. Okay, by the way, thank you for lending your ears to hear my case presentation. And thank you. Assalamualaikum.